Hey guys, it's Sarah here. In this video, I'm going to be going over all the non-medical stuff that you have to know that's part of the NCLEX. So it's just pretty much everything that didn't fit into the other categories. So it didn't fit into med-surg, wasn't maternity, peds, etc. So just before I start, I just want to let you know that all my notes, including this, are located in a PDF form at my website, www.sararn.com, and that's with an H. And you can also get it in the link below. So let's get started. Okay, HIPAA. So just know what HIPAA stands for. It stands for Health, Insurance, Portability, and Accountability Act. And you should know what HIPAA is. It's basically protecting the rights of the patient. So don't give out anybody's information without their permission. You could give out someone's information without their permission if, number one, it's like an abuse situation, so a child or elder that you suspect abuse. Number two, a reportable communicable disease, or when required by law, so like a criminal case. The next thing we're going to go on to is care manager. It says care manager, it's supposed to say case manager. So just know what they do, because they like to ask on that also. It's basically they assess, they facilitate, they advocate for the patient, what they need, you know, do they need referrals, help them out over here. It's kind of like a social worker. That's how I like to think of it. Okay, then we go on to medication error. So you have to know what the steps are if a nurse does a medication error. So they'll ask you, like, what is the first thing you do? So that's like pretty important. The first thing you do when you do a medication error is assess the patient. Then you go ahead and you tell the nursing authority, and then after that you complete an incident report within 24 hours of the error. So the first thing is always going to be assess your patient. After that, you tell the charge or the nursing supervisor, whoever you're supposed to tell, and then after that, you complete an incident report within 24 hours. Okay, the next thing we're going to go on to is what an incident report is. So this is an example, like over here. It's basically when an incident happens that you want to report it. So it's used to document stuff like unanticipated risks for your safety. So it could be for, let's just say, a patient assaulted a nurse or something like that. You know, like why was there no protection? Why was the patient escalated that high? It's pretty much for the hospital to go ahead and research into and figure out how we could not do this next time. And anytime a patient falls, you're going to report that also, even if there was no injury. Hospital equipment failure, you're going to do an incident report, and failure to intervene on like results. Okay, so now we go on to lateral violence. So lateral violence is basically violence from coworker to coworker. So it's not violence from like a director to a staff, it's violence going laterally, coworker to coworker. So obviously, you know, it should not be tolerated. If this does occur, you should document it, keep files of incidents, and report it to your supervisor. And you should basically let the bully know that it's not going to be tolerated. Next, we go on to needle stick injury. So this you also have to know. You have to know what to do. If let's just say you're injecting someone in something and it comes back out of you, or there's a malfunction of the equipment and you end up getting stick. So the first thing you have to do is you should remove your gloves and wash your hands. Always wash your hands. Then report the incident to the supervisor and go to the emergency room. You because what they do in the emergency room is that they draw your blood and you get prophylactic antibiotics, you know, if someone has an STD or something like that. Next, we go on to interpreters. So interpreters is basically, you know, anyone who doesn't speak the language. You don't want them, a lot of people like nod and you'll think that they know what they're talking about, but really they have no idea and it's not really true consent. So you really want an interpreter, and when you have an interpreter, whether it's on the phone or in the room, you always want to make sure that you're talking to the patient, not to the interpreter. So just address the patient as if you're talking to them, and the interpreter will translate. And always get a medical interpreter and someone who's not the family, so they're not biased and they're not leaning to one side. And always get feedback from the patient to make sure that they understand, like have them repeat something back, and address the patient directly. So say, do you, even if you're talking to the interpreter, say do you as if you're talking to the patient. Okay, so here's a question. So the nurse hears a client calling out for help. They hurry down the hallway and find the room and find them laying on the floor. The nurse performs an assessment, always assess your patient first, assist the patient back into bed, notify the healthcare provider of the incident, and then completes an incident report. Which statement should the nurse document in an incident report? Number 1, the client fell out of bed. Number 2, the client climbed over the side rails. Number 3, the client was found lying on the floor. Number 4, the client became restless and tried to get out of bed. So I'll give you a minute. So it's going to be C, because in an incident report, it's not a bias. You're not saying I don't like him, her, this is why. You're literally giving the facts of the event. Okay, so now we go on to events directive. So event directive is basically saying what, it's like a form to let you know what the patient wants when they can't make the decisions anymore. So, for example, do they want to be intubated, resuscitated, etc.? Every patient that gets admitted should have an advance directive because you never know what happened. You know, they come in and then the next thing you know, have a heart attack and you're intubating them and you don't know. So basically, any patient that comes in should have an advance directive on file. As long as they're talking and walking and stuff like that, they're alert, they could always switch their advance directive. They could decide to be intubated tomorrow, not intubated today. But it's basically a form to let you know what to do when they can't make a decision and they can't let you know. The living will is an advance directive describing specifically life-sustaining treatment. So CPR, intubation, mechanical ventilation, feeding tubes, like all these stuff if they want it or if they don't. A durable power of attorney is a document that lets you know which person is going to be the one who's going to make the healthcare decisions when that person can't. So say, for example, a mom makes the oldest child the durable power of attorney. Then that person cannot take over until the mom can make a decision. So if the mom can make decisions and is alert, then you don't go to the next person. And if they disagree, you always listen to your patient. It's just when they can't make it anymore. Informed consent. You always want informed consent. Just because you ask someone to sign on the line does not mean that they actually consented. So there are 3 steps that are involved. Number 1, everything is explained. Number 2, the patient understands all the information. And the 3rd one, which is important, is that the patient is competent and gives voluntary consent. So, for instance, if a patient is unconscious or someone under the influence cannot give consent because they're not in their right mind. Then we go on to leaving against medical advice. So, when someone comes in and even if they're refusing, for example, even if they're refusing to get a catheterization to a life-saving one, if they're alert and they're oriented, you can't force them to stay beyond their, it's not like a jail, whatever they want. If they don't want to get better and they don't want to treat themselves, you have to let them go. But if you have someone who's demented, altered, mental illness, like for example, someone who's a danger to themselves, like suicidal, you're able to force them not to leave against medical advice. You could, even medicate them to make them, restrain them. You have to do whatever you could do to make them not leave against medical advice. But if someone is confident, alert, oriented, whatever they want to do, that's up to them. Okay, so these are just ethical principles that you should know. Sometimes they'll have like these questions and they'll give you an example and say which one's which. So autonomy is basically the patient has the right to make their own decision. It's kind of like I just said before that, you could say, oh, the right thing for you to do is take this medication, you'll be better. The patient has the right to refuse. Beneficence is basically, it's your obligation to do what's good in the best interest of the patient and not necessarily for your interest. Justice is be fair to all. Don't allow just because it's your cousin or your uncle or your family or your culture or whatever. You have to be fair to everyone. Everyone's equal. The next one is non-maleficence, is basically an obligation to do no harm. Fidelity is be faithful, is basically keep your words. Confidentiality is not to disclose the patient's information, like we spoke about before, the HIPAA. And veracity is always tell the truth. So next we go on to complementary and alternative medication. So this is like a whole topic in itself, and a million stuff fall into this. But the only thing that you really should know about the NCLEX is that certain stuff like cupping, they like to ask on us for some reason, it basically could cause circular bruises on the person, but it's not abuse. So don't report it. It's not abuse. Or coining. It's all appropriate. It's part of what they do. Next, we go on to dental avulsion. So this is when the tooth separates from the mouth. So it's talking about someone actually who has a permanent tooth. You know what I'm saying? Not like a kid who the tooth fell out. This is an adult permanent tooth that's separated from the mouth. This is a dental emergency. So you should know what to do until they take over. So you want to rinse and reinsert the tooth into the socket within 15 minutes to reestablish the blood supply. If you cannot reinsert it, then you want to keep it moist by putting it into like sterile saline, etc. Next we go on to hearing impairment. So a lot of patients, they're hard of hearing or just hearing impairment. And so when talking to them, you should know that number one, you should stand in front of them, not like behind them so they could read your lips. Number two, use your hands, gestures to help them out. Number three, never scream. Like a lot of people get really insulted if you talk really loudly and you scream at them. They'll be like, why are you screaming at me? Just try to make sure that they can read your lips, the light is on, you're in front of them, etc. Hearing aids, you want to turn the volume off before you insert them. You should not wear hearing aids when you're putting a hair dryer or heat lamps. You want to check that the battery compartment is clean before inserting them and remove the battery at night. You want to store in a safe and dry place. Next, we go on to crutches. So what you should know about crutches, it's really like a PT thing. A physical therapist will be doing that. But a lot of times they'll be doing the teaching when you discharge someone and you want to let them know these stuff. So if you're fitting someone for crutches, you want to make sure, I would just memorize these numbers because they like to ask, that it should be 1.2 inch space, which is around like 3 to 4 finger width apart, between the axilla, so over here, and the axilla crunch pad underneath. So that's like right over here. It should be 3 to 4 fingers, which is 1.2 inches. You want them to support their body weight on their hands and arms, not over here. There should be like a 30-degree flexion at the elbow, and you want to assess them for the proper gait. So safety with crutches, you want to make sure there's no clutter, there's no rugs. They should look straight and keep their hands free when walking. When they're climbing upstairs, you want to use a modified 3-point gait. So basically, what they do is that they place all their weight on the crutches and step up with the unaffected side. So you stepped up with the good side, and then you should transfer your weight to the unaffected leg and then kind of raise their body to go up. Next, we go on to eardrops. So what you should know about eardrop is that if the patient is older than 3 years old, then you're going to pull it up and back. If they're younger than 3 years old, you're going to pull it down and back. So it's both going back. It's just up for older, down for younger, which is pretty easy to remember. Next, we go on to BLS. So BLS, you probably took a class on that and everything like that, but I was just going to do in like a minute, simplify what you should know. If the patient's unconscious and no pulse, first you say, are you all right, are you okay? So you're verifying their unresponsiveness. No answer, while you're feeling for a pulse, no pulse. Then you have to say you in the green shirt, whatever, go call 911 and bring the AD. And then you assess for pulse, respirations, while for no more than 10 seconds, no pulse, CPR. As soon as you hear the word no pulse, CPR. So for CPR, you want to do at the rate of 100 to 120 and the depth of 2 to 2.5 inches for an adult. Okay, so now we go on to TPN. TPN is total perinatal nutrition. It's basically feeding the patient, but you bypass the GI system. So it's given through an infusion pump and through a central line. The main complication you want to know for that is hyperglycemia, so you want to monitor the blood sugar. So here we have a question. In the United States, access to healthcare usually depends on the client's ability to pay for healthcare, either through insurance or by paying cash. The nurse is caring for the client who needs a liver transplant to survive. The client has been out of work for several months and doesn't have insurance or enough cash. The discussion about the ethics of the situation would involve which principle predominantly. So number one, accountability, because you're accountable for the well-being of this client. Number two, respect of autonomy, because it'll be violated if they don't receive the liver transplant. Number three, ethics of care, because caring to provide for this patient, etc. Number four is justice, because the first and greatest question in this situation is how to determine to get it for them because they don't have insurance. So it's going to be justice, fairness for all. Even if they don't have insurance, they don't have money, you want to give everybody the ability to get health care. Okay, so next we go on to the Bearish Criteria. So what I would know about the Bearish Criteria is basically just what it is. It's like a list that classifies a lot of medications that potentially could be harmful for the elderly. So it's specifically for the elderly. Okay, next we go on to the float nurses. So float nurses are basically you're assigned to different locations every time you come on shift. What you should know about that is that you should be assigned to the place that you're most familiar with. So if you're usually from the ICU and that's where your experience is, you should be placed with ICU patients, and vice versa. A med-surg nurse should not be placed with ICU patients if they're not familiar with it. And if you are assigned, you should speak up and say, I'm not familiar with that, reassign me. And you should get an orientation, whichever one you're not familiar with. Okay, ICU. So what you should know about the ICU is that it's important to maintain a normal sleep cycle in the ICU, because something that could happen is ICU delirium, which is basically when they get disoriented and delirious in the ICU. So you should have a plan of care and don't bother them so much at night, etc. Next we go on to a disaster scenario. So what you should know about that is that in a disaster scenario, you want to do the most good for the most people with available resources. So the patients that are the most salvageable, I guess you would say, go first. So you don't necessarily take care of the most critical patients because they're going to need the most resources and they're most likely not to make it. That's only in a disaster scenario. Okay, next we go on to menopause. So menopause occurs around like 50, 52. It really varies, but that's pretty much the average age. Postmenopausal changes include weight gain, sleep disturbances, atrophy, fat redistribution, etc. You want to educate the patient to eat calcium-rich foods, so leafy green vegetables, do weight-bearing exercises, monitor their cholesterol, and they could seek support to cope. Some complications of hitting menopause include osteoporosis and coronary artery disease because there's a decrease in estrogen. So that's why you would educate them to lift weights, monitor their cholesterol, etc. Next we go into sentinel events, which are basically unanticipated events in healthcare that cause a serious death or injury, but they're not anticipated. Next we go on to Jehovah's Witness. So this is a Christian religious group, and what you should know about them is that they do not accept blood transfusion in any form. So they won't take red blood cells, white blood cells, platelets, plasma, anything that has to do with blood. So if they have a GI bleed or a blood loss and you need to give them blood, to prevent shock, you want to give them non-blood volume expanders, like lactating, Dextran, etc. You could also give them epoetin alpha to help them make more, but you're not giving them blood, or iron IV infusions. Next, we go on to pulse oximetry. So this is basically a non-invasive way to measure your oxygen saturation. It's usually like a little sticker probe that goes on your finger. You should know that it could be falsely low in this situation. Number one, if someone has like really dark nail polish. Number two, if they're hypotensive, vasoconstriction, peripheral artery disease, carbon monoxide poisoning, smoke inhalation, or excessive movement. So then it won't be a true accurate reading. Okay, carbon monoxide. So carbon monoxide, it actually binds to oxygen, so the hemoglobin can't bind, which is why you'll have like 100% O2 saturation, but really they're hypoxic. So carbon monoxide can be from the burning of fuel in a poorly ventilated setting, or from smoke inhalation from a fire. Their symptoms are going to be like really nonspecific, like a headache. You're going to do a diagnostic test, which is the carbon oxyhemoglobin test, and the priority is oxygen because it's not able to bind. So just like ventilate them with oxygen. Next, we go into cyanide poisoning. The thing you have to know about that, the main symptom is they're going to say exactly these words: bitter almond smell. That's how you're going to know cyanide poisoning. Next, we go on to epistaxis, which is basically a nosebleed. Causes of a nosebleed are dry mucous membrane, so someone's like, or local irritation, like someone's like picking at their nose, inserting a foreign object in there, or rhinitis. What you want to do is you want to do direct continuous pressure, like holding it like that for 10 minutes, and ice on the bridge of the nose. The patient should be positioned upright with their head tilted forward. If it doesn't go away, then you could cauterize it, or nasal packing could be done. Here's a question. A registered nurse arrives at work and is told to float to the ICU for the day because the ICU is understaffed and needs another nurse. This nurse has never been working in the ICU, so which is the most following appropriate actions that they should do? Number one, they should refuse to float to the ICU. Number two, call a hospital lawyer, call the nursing supervisor, or report to the ICU and identify the tasks that can be safely performed. So D, so when you float, like I said before, you should always be given an orientation and be assigned to the patients that you're familiar with, like the stable patients or something that you already got trained in. Okay, so next we go on to palliative versus hospice. So the main difference between them two is that if someone's receiving the palliative care, then they could get treatment. Hospice is basically comfort treatment. So no treatment, they're not getting radiation, not getting chemo. But palliative care is they usually have less than 6 months to live, but they're still getting treatment while getting hospice. So basically hospice is only when the person decides to not have treatment anymore. So caring for someone who is dying. So there's a few different things. Number one, for the nurse. So the nurse should have some coping skills, take off time from work, have a support system. When you're caring for someone who's dying, you should also keep in mind the family. You should provide psychosocial support for the family. You should give them honest, factual communication. So don't say, no, they're going to be fine, they're going to make it, if they're really not going to. You want to sit with the family, have empathy, etc. If someone is dying, you want to let the organ donation services know, and if they want, they would continue the cardiac support or respiratory support until they take organs out. Then we go on to postmortem care, which is after the patient dies, the care that you give them. You should know for this is that some religions, they don't want this, so if for religious reasons they don't want it or the family wants to, then you should honor that. But if you are doing it, you should wash, change the linen, make the body straight. You should place like an absorbent pad under them to absorb urine, stool. And you should place the dentures in their mouth and close the mouth, close the eyes, and remove all the tubings, the line, the dressing, etc. The only reason you wouldn't remove the tubing is if they're having an autopsy. Okay, so orthostatic hypertension is basically low blood pressure. There's going to be a difference between their blood pressures when they stand and when they sit or lie down. If someone has this, you should know that they're a full risk patient. In order to perform the orthostatic, what you want to do is you want to take the blood pressure and heart rate when they're sitting, when they're standing, and when they're laying down. You want to maintain each position for 2 minutes before taking the blood pressure, and what you're looking for is a decrease in the systolic pressure for more than 20 or the diastolic pressure for more than 10, and an increase in heart rate for more than 20. Next we go on to falls. So you should know who's at risk for fall, because then you'll watch out for them and do fall precautions. Number 1, if they use assisted devices, so a cane, a walker, that means they're not staying on their feet. Number 2, like we just said, orthostatic hypertension. Number 3 is anyone who takes like a sedative, medication, something to make them drowsy. Number 4, you should watch out for people who are 65 and up, someone with osteoporosis, or someone's on IV therapy. You want to watch out for wet floors. You want to prevent falls, so you want to let them know to exercise regularly, remove all the clutter from them, use night lights, remove any rows, because like you see over here, they could trip right over that. Have a grab bar in the bathroom, non-skid shoes and socks, and wear like an alert thing that alerts a daughter or somebody to let them know if you do fall. Okay, so I made a chart going through the heat-related illnesses. So there's heat cramps, heat exhaustion, and heat stroke, and it goes in that order of best to worst. Heat cramps are basically cramps from intense exercise or really high heat. Heat exhaustion is when you lose water and salt from the body from extreme heat without you properly giving yourself some water or replacement. Number 3 is a heat stroke. Is when the body cannot tolerate the heat anymore, and it's actually life-threatening. So symptoms of heat cramps are going to be cramps, spasm, pain in a leg, arm, somewhere. Heat exhaustion is when you're gonna start seeing like physiological response. So clammy skin, pupils dilated, normal temperature, dizziness, weak pulse, rapid breathing, like their body's trying to compensate. And a heat stroke is going to be the worst, is when they're red, hot skin, elevated temperature, the pupils are constricted, they're dizzy, they're confused, they can even be unconscious. Interventions for all them is that, number 1, you're going to remove their clothing, you're going to hydrate them, you're going to place them in cool air, wet them, ice packs, etc. Okay, question. So which kind is at greatest risk for orthostatic hypertension? Number 1, a 20-year-old pregnant woman at 36 weeks gestation. Number 2, a 66-year-old post-op client on bed rest. Number 3, a 42-year-old client with a history of pulmonary embolism. And number 4, a 70-year-old female who has taken the same antihypertensive medication for 10 years. So let me give you some time. So it's going to be the 66-year-old post-op patient on bed rest, because usually in the OR they give you a sedative or something to knock them out. So that's it. Thank you very much for watching. If you have any questions, you can email me at the email over here. And like always, go visit my website, sarahrn.com, for this in a PDF or any of my other notes. And you can also look in the description box below and check out all my NCLEX series updated by clicking above. Please like, subscribe, and stay tuned. Bye.